Hello, my name is Peter Hammerer. We're here in Amsterdam at the EAU Congress, which is the largest urologic congress in Europe. And I would like to discuss some of the highlights regarding early detection and screening for prostate cancer. On Friday, there was a very interesting session regarding the optimal way to diagnose prostate cancer. With PSA, and I think this is the problem, there is indeed some possible overdiagnosis and overtreatment. So we really have to focus and find these men which do need diagnosis, which do need treatment. PSA is still the most important marker, and risk stratification, I think this is the way forward. So based on the level of PSA, we can really identify those men who are at risk. And if you have a man with really low PSA, the risk that he will develop prostate cancer within the next years is really low. So you can really keep them out. But for those men, with high PSA, high means above 3, you should do a risk classification based on prostate size, PSA density, increase of PSA, family history, and other risk factors. And if you say, well, this man with elevated PSA isn't at high risk based on, for example, risk calculators, then we should offer MRI. And with MRI, if you have a suspicious lesion defined as pyrite 3, 4, or 5, we should, according to the guideline, offer targeted biopsy, and this is also in the guideline, the systemic biopsies. And I think this can be discussed. Maybe in the future we will just go to targeted biopsies, but right now, according to the guidelines, it's recommended to do targeted biopsies based on imaging, and in addition, do the systemic biopsies. For those men who had a biopsy and the risk of prostate cancer is still going up, you definitely should do another MRI. And then I think it's absolutely reasonable to do a targeted biopsy. The question is, do we have new markers? And there are a couple of new markers. There's the Stockholm 3 test. There are actually some papers looking at early detection based on imaging. So maybe with biparametric MRI, we can identify better those at risk compared to PSA. And there were some really interesting ongoing trials, and this was discussed here at this meeting. Also, the role of PSMA PET, is this helpful? And there were a few reports looking at PSMA PET to diagnose prostate cancer in comparison to MRI. And maybe if you combine these two imaging modalities, you can really increase sensitivity and specificity to detect prostate cancer. And maybe in the future, we may not need biopsy. But this is really far away. Right now, prostate biopsy is still needed. Regarding biopsy, how should we do this? And the preferred approach is a transperineal approach according to lower infection rate. The transrectal approach has a sepsis rate of around 1 to 2%. And based on this high sepsis rate, the transperineal approach, which has a much lower infection rate, is the recommended way. So this is new. We should use the information from the imaging results and really identify those men who need the diagnosis, who need to be identified with a significant cancer, which should be treated in a high volume center. Thank you.